Go
Yeah,
ahead.
let's go ahead and talk about. Now you heard, the Swift study, and that most of these fractures will heal if they're put on a cast. But there are certain fractures which have bad characteristics, and the question is, can we pick those up? Can we pick up the bad actors? And we are basically trying to prevent non-union and snag the progression of the bad scaphoid fracture. In order to pick those up, what we need to identify. So we know that interruption of blood supply is a factor in causing scaphoid non-union. And the studies from Oblitz and Holstein in 1938, in which they took dried scaphoids and counted the foramina, they found that the foramina in the waist and in the distal pole, and the very few in the proximal pole. And then the classic studies of Gelberman, Menon, Telesnik, and Kelly showed that there was a lot of vascularity in the waist, and also in the distal pole, but very few in the proximal pole. And subsequently, the recent studies by Steve Moran showing the injected specimens and 3D CT, micro CTs showing that the distal pole and the waist, and very few vessels in the proximal pole. So we know that. Now there are other things, and we mentioned this. Nick mentioned this, and Dr. Jupiter mentioned this also. Failure to recognize the fracture, inadequate initial treatment, and improper assessment of bone healing are causes of preventable cause of scaphoid non-union. Failure to diagnose. In many series, you'll find that 50 and over 50% of their series, they didn't seek adequate initial treatment. In Radford studies from Cambridge, in our study, 65% did not have adequate initial treatment. And von Schroeder studies that Nick mentioned, over 50% did not have adequate initial treatment. So does it matter? Well, Langloff and Anderson showed that delay in diagnosis of less than 4 weeks, the union rates are the same as fresh fractures. And if the delay in diagnosis is more than 4 weeks, if you're treating them non-operatively, then there is a higher rate of union. So the other thing is improper assessment of bone healing, and Jesse Jupiter mentioned this. So you see this fracture, you think it's healed, you take the immobilization off, patient goes away, comes back a year later with the fracture not healed. And this is more important if you're doing assessment of healing by X-rays. And Joe Dias has shown this in this classic study in '88 when he took 20 good quality X-rays at 12 weeks post-injury, and he sent it to 8 of his good friends, 4 orthopedic surgeons, 4 radiologists. And 2 months later, he shuffled them up and sent the same X-rays to the same observers. And what he found was there was poor intra and inter-observer correlation of bone union. Not only did they not agree with one another, they did not agree with themselves 2 months prior. So the conclusion was that radiographs at 12 weeks do not provide reliable and reproducible evidence of healing. You need to do a CT scan and see if this thing is healed or not. So, but what are the characteristics of the scaphoid, the fracture itself? Well, there are a few. One is a displaced fracture and a comminuted fracture. And this has been known since 1981 from Leslie and Dickinson's classic study. Unstable fractures, fractures which have different patterns of fracture which can separate out, fractures with carpal instability and deformity, and proximal pole fractures. So these are the 4 characteristics which we'll talk about. And obviously, if you turn them around, then these are the indications of primary ORIF or CRIF: displaced and comminuted fractures, unstable fractures, fractures with carpal instability and deformity, and proximal pole fractures. What about displaced fractures? Well, it's been known, and many studies, especially Edlund's study in 1975, that 19% non-union rate. When the fracture was displaced more than 1 millimeters, the non-union rate was 92%. And then the recent studies of Joe Dias, some meta-analysis, and also Graywall and Nina Su studies showed 22% non-union displaced and comminuted fractures. So this is quite apparent. The displacement of this fracture is quite apparent. But then there are fractures which have subtle displacements in different planes, and you can pick them up on X-rays. But sometimes you need CT scans. Now, if you want to call it an undisplaced fracture, you should make your criteria very strict. Lack of any displacement. Scapholunate angle has to be less than 60 degrees. The interscaphoid angle has to be less than 30 degrees, coronal interscaphoid angle less than 40 degrees, and absence of any comminution. So these on CT scan, this would be probably considered non-displaced fractures. There was a study from Europe, and also David Ring was there. They showed that displacement and plain X-ray diagnosis sensitivity is not that good. It improved much better with CT scans, and also the accuracy of diagnosis was much better with CT scans. Well, Joe Dyson did a meta-analysis of all the literature, and they found that odds of non-union are 17% when displaced fracture treated in a cast compared to surgery. And they looked at historical series of fractures treated in a cast, historical series of fractures treated by surgery. And they looked at different series. They said displaced fracture have 4 times higher rate risk of non-union odds ratio with confidence interval 2.3 to 8.7. So, and then there was a study from Ruby and Nina from Canada, and they looked at displacement. They looked at all these displacement in different planes. They also mentioned comminuted fractures, and comminuted fractures are definitely displaced fractures. And if you have comminuted fractures, those are bad actors. So humpback deformity, I talked about it, 7 times rate of non-union. Translation is 3.4 times rate of non-union, and comminution is 2.5 times rate of non-union. The next step is, what about unstable fractures? What are unstable fractures? Well, McLaughlin 54 and Herbert and Fisher in 84, they talked about this vertical oblique type of fracture, which displaces, because when you have a transverse fracture, it can compress, and when you have a vertical oblique type of fracture, the fracture ends can displace. It's a simplistic view of instability. When you have situations like this, a vertical oblique type of fracture associated with comminution, this could be a bad actor. So early internal fixation would result in better prospect for the patient. When you have displacement or instability like this, when you see the instability through a mid-carpal portal, then you can fix this, reduce them and fix them adequately, and you get a better result. This is quite apparent. The instability in this is very apparent here, and you have to reduce this. This is a fracture which has got a vertical oblique type of a pattern, and with the CT that confirms it. So this type of, so instability can be defined in these terms, in terms of the angles. Again, Boozy and Ring showed that instability can be better diagnosed with a CT scan rather than with a X-ray. But even then, if you get more information, if you do a mid-carpal arthroscopy, then you find that even the ones that are shown to be non-displaced or stable on CT, about a third of them are shown to be unstable on arthroscopy. So here's a patient which is displaced a little bit, fairly stable looking CT and plain X-ray. But if you look at the, if you do a scope, so this is the scope first through the radiocarpal portal, radiocarpal view, shows some of the comminuted segments, comminuted fragments that we saw earlier in the X-ray and CT, some loose bony fragments. And these would be definitely an unstable type of fracture. Then you see a mid-carpal view, and you'll see that this is scapholunate area, and then you go further into the there's a separation of scapholunate, widened scapholunate interval, and you go further looking at the fracture, and you'll see that there is definitely, you put in the probe, and you can see the fracture fragments are widely separated and displaced. So this is obviously, as you get more information with an arthroscopy, that shows that it's displaced. What about the third segment, fractures with carpal instability and deformity? Fisk, in 1970, in his Hunterian lecture, drew our attention to this. that these fractures are bad and you have to reconstruct them so that the geometry is reconstructed. And Fernandez talked about bone grafting, so it became known as the Fisk-Fernandez method. Or associated with carpal instability. So if you have situations like this, these are very bad actors and they have to be fixed primarily because they're in two different towns. So here's our patient that we saw earlier with CT scan showing that there is a humpback deformity and there is a DZ deformity there. The fourth characteristics that we can pick out are proximal pole fractures. Again, these are bad actors. Rettig and Raskin showed that they don't do well with cast fixation, that you have to fix them primarily. And there have been other publications showing that 34% progressed to non-union when treated non-operatively. So primary fixation of these fractures is very important, and it's been shown over and over again in the literature that that is the case. And again, Joe Dias and Easley's paper, 7.5% risk of non-union with fractures managed non-operatively. So this is a case when there is a little avascular, dysvascular proximal pole. I would not call it an avascular necrosis, a dysvascular proximal pole. And even these can revascularize once they're fixed stably and reduced, resulting in very good outcome. So pro-prognostic indicators are displaced fractures and comminuted fractures, unstable fractures, fractures with carpal instability and deformity, and proximal pole fractures. So indications of primary management are displaced and comminuted fractures, unstable fractures, and fractures with carpal instability and deformity, and proximal pole fractures. So the take-home message, same, repeat after me: displaced fractures, comminuted fractures, unstable fractures, fractures with carpal instability and deformity, and proximal pole fractures. Additionally, there are improper early management and improper assessment of bone healing. All right, thank you.